Good evening, friends. In fact, I'm very happy to host yet another prime time. This is definitely getting more and more exciting with more and more advanced laparoscopic topics coming up with more intensity, and faculty who have committed themselves the entire career towards advanced laparoscopy. I thank Professor Sunil Papat, sir, for guiding us with more senior and eminent faculty and more tougher and tougher topics, so that the IAGES Prime is getting more primer by the day. I'm happy to introduce our president, Professor Sunil Papat, for people who are out of IAGES. Professor Sunil Papat is an advanced laparoscopic surgeon by himself. He is an ardent endotherapist. He has special interest on foregut and hernia surgery, and he has got his fellowship from the Edinburgh and has been instrumental in propagating the field of surgical gastroenterology in that part of the country. As well, he has been past president to the Ahmedabad Surgeon Society. He has represented the GC, and he has been an ardent academician, hosting the IAGES National Congresses and many fellowship programs, as well as advanced fellowship of laparoscopic surgery in Ahmedabad. Said that, he is an eminent academician and an ardent teacher himself, and he is a very brilliant documenter of all the surgeries. With that few words, I invite our president, Professor Sunil Papat, to welcome and give his presidential address. Dr. Sunil, sir.
Thank you very much, Dr. Kanagwal. Good evening, friends, IAGES members, our today's dignitaries, keynote speakers, Dr. Abhay Dalvi, Dr. Ajay Kriplani, and moderators, Dr. Jaideep Palep, Dr. Minakshi, our convener, Dr. Kanagwal for digital programs, and Honorary Secretary, Dr. Ishwar Murthy. Friends, IAGES is almost going to finish third decade of its existence in a couple of years' time. Since last 1 year, since we ventured into this COVID pandemic time, IAGES moved into the digital age and came up with so many digital programs. IAGES Prime Time is running very smoothly, and almost every fortnight we are meeting on this Docplexus platform to discuss issues related to laparoscopic surgeries, advanced laparoscopic surgeries, GI endoscopies, complications of the GI disorders, and complications of the procedures. This is keynote lecture number 11th and 12th today since February. And we are very fortunate to have two eminent speakers, Chief Trustee of IAGES and ASI President, Dr. Abhay Dalvi, past President, Trustee and Advisor of IAGES, Senior Laparoscopic Surgeon, Dr. Ajay Kriplani. Friends, we are very happy to share with you that last time, before 15 days, we had almost 1,000 members listening to IAGES Prime Time on Docplexus platform and many other on YouTube and Facebook platforms of IAGES. The way the academic program is being handled by all the IAGES digital team, I am sure very soon we will be reaching the audience level of few more thousands. I'm very happy to be here among these dignitaries, and without much delay, I will invite Dr. Kanagwal to start the proceedings. Thank you.
Thank you, Mr. President. We move on to the program directly. May I have the honor of inviting Dr. Jaideep Palep. Dr. Jaideep Palep is an eminent and advanced laparoscopic surgeon from Mumbai. He consults at Nanavati, PD Hinduja, and Lilavati hospitals. And he is a brilliant student from KM Hospital. And later he did his master's from the Topiwala National Medical College. And he has been teaching faculty for almost 12 years. And then later he has a passion towards advanced laparoscopic surgery. And he's one of the very early adapters of bariatric surgery as a specialty by itself. And he has more than 25 original publications to his credit. and he represents IAGES as one of the executive committee member and has been faculty to almost all the academic programs by the IAGES and the advanced laparoscopic surgery programs. With that few words, may I have the honor of inviting Dr. Jaydeep to take over the first half of the program. Dr. Jaydeep, please.
Very good evening to all the surgeons attending this program. Thank you very much, Dr. Kanagwel, for the introduction. Respected President, Sir, the Chief Trustee of IAGES, ASI President, Dr. Dalvi, Dr. Kriplani, past President, and all my colleagues today. We have a super show lined up here today. We'll be starting with Professor Abhay Dalvi. For us all in Mumbai, we fondly know him as A&D. For people who have passed out from KEM, from GS Medical College, I was a student there and he was one of my teachers in the Department of General Surgery. He joined this department, or he joined the college rather, in the mid-70s, and he only superannuated just last month, or in April 2021, at the end of the month, after doing his MBBS, his post-graduation, and being part of the general surgery department for so many years, and one of the most favorite teachers in undergrad and in postgraduate education at the KEM hospital, also in Mumbai, in all the municipal and government teaching hospitals. Yeah, for all of us, he's fondly A&D sir. He has many credits and he's very popular for his advanced laparoscopy skills, which he started developing in the 90s in KEM. He was one of the founders for minimally invasive surgery in KEM Hospital and St. GS Medical College, and took it to national and international heights. He has more than 50 publications in international and national journals. His liking for the adrenal gland and adrenalectomy is well known to us. He has won many fellowships and awards and has them to his credit over the last 3 decades of his surgical practice. Presently, he is also the president of the ASI and the chief trustee of our association, the IAGES. And one of the things which I would like to mention here, although against his wishes, but he was invited to SN in 2019 to Professor Martin Wolf's center in Germany. And he wanted to see his way of doing the retroperitoneal approach for the adrenalectomy. This is Professor A&D, after doing more than 350 or 400 adrenals transperitoneal. And he lapped it up so well, and he had so many interesting discussions with Professor Martin that he was ready to give him the opportunity to operate and perform the retroperitoneal adrenalectomy in Germany without a license. However, knowing him, we would do that in being an Indian surgeon, not having a license. So this is Professor Dalvi. I will hand over the proceedings to Sir. And let us hear some tips and tricks on how to do a left and a right-sided adrenalectomy minimally invasive. Sir, good evening and welcome.
Thank you, Jaydeep. First and foremost, Mr. President, Dr. Sunil Popat, Honorary Secretary, Dr. Ishwara Murthy, Dr. Ajay Kriplani, the past president and a senior surgeon, conveners of this program, Jaydeep, convener Meenakshi to come in next, Docplexus team who is hosting this talk of mine, and obviously people who are seeing in the audience. Very good evening to you, and I am proud and pleased and privileged to deliver this lecture on laparoscopic adrenalectomy tips and tricks. I definitely know that once I talk tips and tricks, my practice is going to go down, but it's okay, doesn't matter. I will be very happy because after 36 years of teaching career, I've taught so many people who have become really good at advanced laparoscopic surgery. So what is the first tip? The first thing that we realize is that endocrinologist is the ringmaster of a complete circus that takes place around the adrenal glands. If the surgeon forgets that the respect to endocrinologist is not there, Then there is ahankar. And what ahankar means is pride. That completely gets destroyed if a patient succumbs to your surgical techniques. So what are tips and tricks over the years that I followed? Number one, I always believe that endocrinologist is the captain. Say GS Medical College and KM Hospital and the endocrinologists in private practice are the leaders as far as I am concerned. They are responsible for optimization even if it is a non-functioning tumor. We are just carpenters. Architect is someone else. The second important thing is good vision. And when I say good vision, it does not mean 4K system or this system or that system. It is the team and the vision. Not only the camera person, but also the assistants who really help you in difficult times. The third important thing is knowledge of anatomy, because the principle of adrenalectomy is not to injure any surrounding organs, and there are many. Reading your imaging is of utmost importance, because this is one thing which the endocrinologists possibly do not know. You should have proper energy sources in your armamentarium. You should select an approach which is the best suits you. And when it comes to procedures, it's about creating planes, dissect for safe surroundings, reach the target. Target is usually the adrenal vein, though the literature says that adrenal vein can be tackled last. Staying away from the gland, Michel Gagnère, who is another pioneer in adrenal surgery, has always defined it as dissect the body away from the adrenal, especially in pheochromocytomas, and last comes the retrieval. So what is the role of endocrinologist? It is the role of diagnosing what is the problem with the adrenal gland. For simplicity, they could be functional by hypersecretion of hormones. Medulla secretes noradrenaline, norepinephrine, and epinephrine, giving rise to pheochromocytomas. Cortex producing tumors are Cushing's, that is cortisol, leading to obesity, making life difficult for a surgeon. Cons is the best thing to start. Other secreting tumors are testosterone or female hormone secreting tumors. It's very easy to say tumor is non-functional, that is incidentaloma, but these also by size can give you trouble. And overtly malignant on imaging above 6 centimeters without infiltration can be tackled by minimal access technique. When I come to the team, the role of laparoscopic assistant, that is camera, is extremely vital. The other assistants, including the scrub nurse, are also part of the team, because at places where you require something in emergency, they become extremely important. These two, if they are good, then it allows the surgeon to focus on crucial elements of an operation, and that provides safety and efficacy for the patient. Remember, in functioning tumors, especially pheochromocytoma, despite a good blockade by the endocrinologist, the patient can get into trouble, and that's why the role of anesthetist should be respected and not underestimated by a surgeon. Let's see what is an adrenal gland. On the right side, it is surrounded by the liver. In fact, the liver sometimes hides it. Kidney, duodenum, hepatic flexure, and most important loving member of the team is IVC. On the left side, you have the diaphragm, the spleen, the pancreas, kidney, and other organs which are important. It's very important to avoid injury to these structures. How God has made adrenal gland? And this I realized only when I started doing laparoscopic adrenalectomies and I read anatomy. There are multiple small arteries which supply the adrenal gland, and all are from the medial aspect. No supply comes from superior, inferior, lateral, anterior, or posterior. So one thing you understand as a surgeon, that if you get the plane correctly on the medial side of the gland and take control, the entire artery supply is gone. God has given us something more even further, that the right adrenal vein enters directly into the IVC. It is short, stumpy, and can become of huge size when it comes to ACC or a pheochromocytoma. And on the left side, it enters the renal vein. Investigations of important surgeon, because once the endocrinologist calls you that this patient is to be operated, the adrenal protocol CT scan, which is being followed at least when I get a patient, I look at the plain phase, the arterial phase, the venous phase, and the late phase. And obviously, if required, MRI is done. Now, why imaging and what is imaging of importance to a surgeon? Location and size, the relation to adjacent structures and whether fat planes are maintained. In pheochromocytoma, you can have vascularity, so you can actually look at neo veins, larger veins, and engorged arteries. Carcinoma, you look for infiltration and size. And in Cushing, you look for how much of abundance of periadrenal adipose tissue is there. And that can tell you what difficulty you are going to get, especially when you are operating an obese Cushing. These are just sample slides that I've tried to show you. This is the plain phase. This is a relatively large tumor. It is becoming hyper intense in arterial phase. And even in venous phase, it is not the same as seen in the plain phase. Whereas if you see aldosterone secreting tumor, it is in the plain phase, little bit here in the arterial phase that you can see, and you can also see it. So hypervascularity is almost absent in cons, whereas too much in pheo. And why I'm trying to tell you that is also look at this tumor. It is big. It has compressed the IVC, gone beyond it. So you know that you will have to go behind the IVC and retract the IVC to tackle this pheochromocytoma. Whereas cons is quite away from the vein and can be easily is going to be easily tackled. Let's come to energy sources. Standard electrosurgical unit is always available in the operation theater. Ultrasonic scalpel is available in most centers which are doing advanced laparoscopic surgery. You can have a dedicated bipolar sealing system like Ligashore or anything else, or you have other instruments which have combination of ultrasonic as well as dedicated bipolar systems. All are extremely important. In standard electrosurgical unit, bipolar is very important in cases of difficulty because it can actually coagulate things which your ultrasonic cannot. I have worked in public institute as a professor of surgery and in corporate hospital. At KM hospital, we have only ultrasonic scalpel and electrosurgical unit, and that is why bipolar becomes an important armamentarium. The approaches that have been described in literature are transperitoneal, which is the commonest one that a general surgeon converted to laparoscopic surgeon or a endocrine surgeon will do. Retroperitoneal requires a little bit of effort, which I have realized. And third one is a transmesocolic, which has been described by Lejose et al. For left-sided tumors, where he says that the operative time comes down quite a bit because the transperitoneal left-sided requires a lot of dissection. In positioning also is extremely important, both in transperitoneal and retroperitoneal approaches. We have performed around totally now 413 adrenalectomies. I started in 2001. I remember I took 4.5 hours. I had to do it without harmonic scalpel, but luckily for me, everything went well. And that is the time I realized the importance of teamwork. And I said to myself that if I can keep these 3 or 4 people with me, then only the department can develop into a center which will be recognized for adrenalectomies. The position is bang lateral and the patient is fixed. The issue is targeting the adrenal vein, and as I've already said, dissect the patient away from the tumor. So let us see what is left adrenalectomy. The port placement. The port placement is, the telescope is usually about 1.5 to 2 inches lateral and above the umbilicus. But again, let me tell you that this is not a compulsory thing. You have to read your CT scans. Many a times on the left side, the tumor can come more medially, and then this telescope is not able to show you because in spite of retraction of the spleen, the right hand is going to dissect, left hand is going to retract the spleen, and there is always a helper or an assistant, and this person is extremely important who helps you in actually dissecting the adrenal vein in difficult situations. So let us see. The first step is to get into the correct plane and dissect the splenopancreatic complex away from the tumor. Now, this is a huge tumor which I have demonstrated in one of the workshops. It was about 7 to 8 centimeter solid tumor, but had not infiltrated. So here, once you reflect, you can see the splenic artery pulsating. The splenic vein also is seen, and this is the space which opens up as the splenopancreatic complex falls. The tumor remains where it is because it is fixed to the diaphragm and the retroperitoneum as well as the kidney, and the planes just open up. So it has opened up quite well. Now, splenic vein is usually the marker for the renal vein. So you start dissecting somewhere around where the splenic vein is seen, and you are around the adrenal vein. At this point of time, you will realize that I have decreased the harmonic to 2/5 because I know that medially I'm going to tackle all the arteries. This is the aorta, and I am just tackling the medial side. As I told you, if I can get rid of the medial side, half the vascularity or almost the vascularity goes away. Then comes the renal vein. Now you will see the retraction that is being done, and this is my assistant. Because of the fourth port, he or she is able to clearly go around, because the angle that I have in my right hand is not the one which is the correct angle to go around the larger vein. So that is another tip, important to have a fourth port. So I'm just in this workshop, I'm demonstrating that this is the splenic vein, this is the thing, etc., etc. Remember, clipping the specimen side is the most important thing, for simple reason that in a functioning tumor, you can have, if you go on the other side, you can have engorgement of the vein, especially if the arteries are not completely blocked. Once that is done, a close look. Now, this is importance of imaging. I knew that the tumor was arising from the superior pole of the gland, and I had to look for, if I had blindly gone, I think I would have cut somewhere here and only enucleated the tumor without a complete adrenalectomy. Yes, partial adrenalectomy is known, but this is what you do. Once the adrenal vein and the arteries are done, is just fishing around in the periadrenal area. I'll just go a little faster, and then you just dissect it off the retroperitoneum as well as the diaphragm. And that is how the entire surgery on the left side can be completed. So this is the last thing that can happen in this. Obviously, this tumor is bagged and then taken off. One important thing which I will keep on repeating when you are doing adrenalectomies is, do not think that hemostasis is complete because there is no bleeding. You have to be sure that the BP is up above 120 before you start reverse actually closing the patient. So a close watch is necessary. As far as the right adrenalectomy is concerned, it is little tricky. The telescope, as I said, is similar on the right side. One should know, the tip is that your left instrument should go bang parallel to the IVC. So you have to mark out where the IVC is like to be, and that will be the left-hand port. That way you decide where the telescopic port is. There is a liver retraction port and a right-hand port. Right-hand port is usually perpendicular to the IVC. Left hand is parallel to the IVC. And when required, you require a helper port on the left side, which is in the anterior axillary line. So this is a video of another large tumor. And you will see here that, I'll just go back if you don't mind. You will see here that I have mapped out. This is a large tumor. The IVC is compressed. It is going behind the IVC. So I have to be little bit of care. I have to take care that I do not dissect too much. So the first thing that you do on the right side is to go parallel to the IVC and try and get into the retroperitoneum as fast as possible. Now, the trick is get parallel to the IVC and then go ahead right up to the right triangular ligament of the liver, so that the peritoneum is dissected and the superior part. This liver retraction is extremely dynamic. Once you get this sort of plane, then you try and mobilize the liver and push it as high as possible so that you can have superior control on the adrenal gland. Then you come down and start dissecting around the superior pole, or try and get. So I'm marking out, this is likely to be the vein, and you will see the tumor is large, the vein is also quite big. The left hand helps you. You can use Maryland if you want. If your left hand is good and stable, you can actually lift this vein with this instrument, and that is the greatest advantage, because this left instrument becomes perpendicular to the vein, and any instrument which is perpendicular to a vascular structure becomes very easy to dissect through. Now that I have identified the vein and dissected, the important thing, and noted that this vein is slightly dilated, I know that if I clip it, the gland is just going to increase further in size. So I go for the arteries, which I said come from the retrocaval region, and the arteries are clipped and then tackled with any energy source. Nowadays we use harmonic. My first 30 cases I did only with simple hook and nothing else. Now this is the one which is going behind the IVC, and you got to be very, very careful in seeing that you dissect the entire gland properly and retract it away from the IVC, and that is the importance of getting into the retroperitoneal plane and retracting the gland laterally. One caution is, if the vein was small, then I would have possibly clipped the vein. Here, retraction can lead to excessive traction on the vein, and you can have avulsion. I will show you one video where foolish mistake of mine has led to this. Once clipping is done and the vein is divided, again the same principle followed, that you remain in the periadrenal tissue and dissect the gland off. So I'm not going to go ahead. You can see the retroperitoneum here, and this is the extent of the gland which will have to be tackled. It's this hand which is helping me to retract it away from the IVC and getting into the correct plane. There was a small bleeder in this case, that's why I had put in a gauze piece. And in this case, bipolar became very handy for me in absence of ligashua, because with harmonic I would not have been able to coagulate it, and you can see that I have coagulated it. And now it's just going through the periadrenal tract and just finishing off the adrenalectomy. So the tips and the tricks of right and left adrenalectomy is correct close port placement and having instruments and good assistance in hand. Retroperitoneal approach, we went basically on repeated requests of Dr. Samir Rege, the professor of surgery now, and I have to go on record that he is continuing the same OPD that I was running. We have limited experience. We always feel that we should start learning with smaller non-functioning tumors or like cons in the initial phases. We have realized that right is easier than the left. And as I said, even a better team and discipline is absolutely necessary. So this is a video of right, actually a bilateral adrenalectomy for Cushing's. These are the port placements on the right side. These are the port placements on the left side. And that's the greatest advantage of retroperitoneal, especially in bilateral setting. That only thing is that giving position is of utmost importance. If the position is bad, then everything goes haywire. And pay your money if you want to learn retroperitoneal adrenalectomy. Go to Germany, see the way the positions are given, because we do not have those tables, at least at KEM hospital and even at private corporate hospitals. we have to innovate. And this innovation thinking has to be done by us after coming here, for which again I give due credit to Dr. Regi. So the first step is to actually open up the retroperitoneum, for which there is a fascia which has to be incised with scissors, and then you put in your working port. Now remember, there are 3 ports out here. This is a 5 mm port, this is going to be a 10 or 12 mm port, and the one is going to be paraspinal. Now what you are looking at this video right now is that both the instruments are coming from one side and the telescope is in the paraspinal region. The first thing that you do is have to bring down almost everything from the retroperitoneal muscles. That's the first step. The second step in right adrenalectomy is to know where the kidney is. Even on the left side, it is kidney which is important. Once you have demarcated the kidney, then you start going to identify where the IVC is likely to be. It becomes easier in a patient of Cons. This is a Cushing's where bilateral is being done. That's why you will see a lot of fat that is there. But with slow dissection, you will see that I have identified the IVC. Now that IVC is identified and you know that the vein comes posterior superior and gets this, you go as lateral as possible. That means I am on the posterior aspect of the IVC and dissecting. The left hand keeps on dissecting, the right hand keeps on cutting. But it's most of the times, if planes are well maintained, it is nothing but just dissection that takes place. Just pushing the tissues away gets you into the correct one. You keep on going upwards till you can, and then you come on now the liver side. You can see the liver will be somewhere here. I am pushing the entire adipose tissue. I have yet not seen the adrenal gland at all. And what I am trying to do is now get into a structure which is a pyramidal structure. See the gland out here. So I have almost reached the top from this side. I have almost reached the top from this side, and you will see that it's a triangular thing that is there, that is created. And this triangular pad of fat has to be removed as far as retroperitoneal adrenalectomy is concerned. As you dissect and keep on dissecting the adipose tissue, you are not looking at the adipose tissue which is being connected, cut, but you are looking for the vein. And that is what is important. So dissection of the superior pole is almost complete out here, and the IVC will be somewhere here. You can see the adrenal vein here. And remember, it becomes very difficult for a surgeon who is done transperitoneal approach to really invert himself and start looking for the vein. And that's why initial commitment to the team is very, very important. Now that from the IVC side, I am reaching the top, as you see here. And now that the vein is, now never ever completely separate the adrenal gland and then go for the vein. Always let the adrenal vein be attached to something, because just adrenal vein can get avulsed if at all the entire adrenal is separated. This is my tip of the day for all those who are going to do retroperitoneal adrenalectomy, because I have faced it once. And on the right side, if at all that happens to you, you are going to be in deep trouble. We still struggle because we still struggle with position. We still struggle with putting in the right type of ports. Everything looked very nice when we saw retroperitoneal adrenalectomy in Germany, but we are still trying to polish it. But we will never walk backwards, because I think retroperitoneal adrenalectomy, when I saw the patient operated in the morning, go home in the evening, I could not even identify the patient. As it is, when the patient was brought into the OT, the patient was prone, so I could not see the face. When we went for around, the patient was already dressed up to go home. It was only when Martin Waltz told us that this is the patient we did in the morning that I realized the importance of retroperitoneal. As far as our journey in adrenalectomy is concerned, we have published till now 3 articles, 2 in Journal of Minimal Access Surgery, 1 in the Indian Journal of Surgery. As I said, the first article was laparoscopic adrenalectomy gaining experience by graded approach. The second one was has experience changed the scenario because we had started doing larger tumors, and ultimately laparoscopic adrenalectomy for large tumors, a team experience was published again in 2013. After I came back, having given a faculty podium presentation on adrenal tumors, which is quite rare to go there and stand on the podium and give such a lecture. Let me cover paragangliomas since this has been given to me. Paragangliomas are nothing but brothers and sisters of adrenal glands. They are almost always functional, especially pheochromocytomas. They can exist anywhere around the neuroendocrine axis. The commonest one that is described is angle of Zuckerkandl. There is a little bit of confusion whether it is between the IVC and the renal vein or between the common iliac and the. Anyway, these are the ones which are to be removed. We have now experience of 52. This comes from the last thesis that has been submitted to the Maharashtra University of Health Sciences by my student. Commonest organ is Zuckerkandl. As I said, different locations are there. You have to plan it after seeing the CT scan. Relation, important structure, especially ureter, if it is in the organ of Zuckerkandl, is important. Close port placements cannot be made. They are different only after seeing the CT plates. There is no definite vascular pattern, but they are vascular and hypervascular. And all the feeders come from aorta, luckily. And that's why the medial aspect of the tumor should be taken first. So if you see this CT scan, you will see that this is the tumor and this is the aorta. If you see it more carefully, it is very near the duodenojejunal flexion. So my planning would be that I have to see the duodenojejunal flexure, which is a nightmare for if at all it gets injured. Under any circumstances, should not be injured. So let's see this video. So that's the DJ flexure you can see out here. And this is the tumor which is sitting out there. So the first thing that I do is go ahead on the medial aspect, because I know that medially all the feeders will be there. In fact, treatment of excision of paraganglioma we published, I think, way back in 2011 in one of the international journals at that time. You will see that I am going through the medial aspect, hoping that I will get rid of all the arterial feeders and the rest of my dissection will be easy. So this is the medial dissection. You will see a good large vein out here. The inframesenteric vein is somewhere here. I did not know what this vein was. I only was concentrating that entire thing has to be pushed aside and the tumor has to be removed. Also, keep a watch. I know at that level ureter will not trouble me, but having done previous ones which are in the organ of Zuckerkandl, I knew that ureter is one thing which can give us trouble. So all the time, repeatedly, I was telling myself that you be very careful along the medial aspect and on the posterior aspect. So see that the medial aspect is now clear. Now I try to push everything, this vein, especially laterally. So I dissect between this vein and the tumor. So now what is left is the superior aspect and the posterior aspect of the tumor, which I will tackle a little later. So I'm just running the things a little this. One thing I have learned in adrenalectomy is retraction is of utmost importance. And if you are going to fear bleeding, then sometimes controlled suction in the left hand also acts as a good retractor as well as keeps the field clear. So that's one other tip that I am trying to tell you. You will see in the future video or that in my left hand usually there is a suction. So in difficult situations, I use suction in my left hand. See here, you can see here, there is a little bit of bleeding that is taking place. So I have a suction here which is sucking, which allows me actually to catch hold of the oozer and cauterize it. Now this, it has to be controlled with the ball of the thumb so that excessive suction of gas does not take place. Having done posterior dissection, now we are just going through rituals of completing the dissection, because I know nothing is superior and nothing is inferior. So that completes excision of paraganglioma. Obviously, everything looks good and cozy, but this is a video you will see where I thought that I had, I'm sorry if it's not running, but there is a big bleeding that takes place, you will see here, and I have managed to control it with harmonic. I'm extremely sorry that this video was running, but something has gone wrong, but at least I can show you that adrenal vein on the right side has started bleeding. It is the role, sorry. So you have seen this, what has happened. It's the team that has helped me to dry the situation and apply the clips. I'm sorry the video is not running, so I'll just yeah, okay. So it is nothing but the team that has helped me to control the vein. You will see here on the right side, this is the retroperitoneal adrenalectomy. What these videos, I don't know. It's taking time to upload. Anyway, I will share this video sometime. What I want to show you is, look at this adrenal. It is completely separated and hanging on the vein. And while trying to introduce the clip applicator, my left hand forgot to balance it, and it just evels the vein. It was only again camera person and the team work that helped us. One more thing helped us, which I forgot to tell in the retroperitoneal adrenalectomy, is that the pressures that are used are much higher. The pressure that is used is about 26 to 30. Martin Walsh used 34 and uses Liga Shower, does not even bother to clip the veins. So he is very fast in doing this. In absence of our anesthetist not going beyond 20 or 24, it becomes really difficult. And nothing gives you more pleasure when you see this 8 or 9-year-old chap being subjected to transperitoneal bilateral adrenalectomy for Cushing's. This boy is from Bangalore and he's done well. Every year on his birthday, mother sends me his photograph, and this was immediate post-op. This was about 6 hours and this was about 8 hours. And this is the patient which you saw bilateral adrenalectomy being done in the morning at 7 o'clock around. This is what the video was sent to me by my registrar, that should we start orals when the patient was already walking. And that's the beauty of adrenalectomy. Remember one thing, in any advanced procedure, no one whistles a symphony. You require an orchestra. And I take this opportunity to tell everybody who is listening the credits. Dr. R.D. Bapat, who has been my mentor in open surgery and pushed me into laparoscopy, and he used to do all open adrenalectomies, and he was the first one to tell me that do this case laparoscopically. The entire gamut of endocrinology team of St. G.S. Medical College and KM Hospital, a huge department, gets a lot of adrenals. That's why I am here. The anesthesiologists who have always helped us in anesthetizing even tricky patients. Dr. Pinky Thapar, who was one of the first ones to be with me for adrenalectomies. Dr. Samir Rege, unfortunately, she left for private practice and is doing very well, doing adrenalectomies in her own way. Dr. Samir Rege, who has literally been my right hand or left hand, you can say. And then after Samir Rege, Dr. Mahadev Garle and Yogesh Takalkar, who worked with me for about 7 years and held the camera for me. Obviously, I have to give due credit to all the resident doctors, including the last two, who helped me to take out the data of not only adrenalectomies that I have done, but even paraganglioma. and always worked up the patient and saw to it that the patients were on table. There is nothing less but more important that the healthcare workers giving positions for retroperitoneal adrenalectomy as well as transperitoneal adrenalectomy, as well as the scrub nurses who wash up. There may be others whom I have missed in this huge journey of mine as far as laparoscopic adrenal is concerned. I thank IAGES again for recognizing my contribution towards adrenalectomies. And if there are any questions, I am ready to take. Thank you, Dr. Popat. Thank you, Dr. Jaideep. Thank you.
Thank you very much, sir. It was a really beautiful, lucid talk on adrenalectomy, minimally invasive for the left side, right side, and also covering the other tumors. And there are a couple of questions from the audience, sir, if you permit. Is there any particular preference of the number of clips that you would use on the IVC, on the body side?
Clips are never applied on IVC. They are applied on adrenal vein.
All right, great.
The thing is one clip on the specimen side, right, and 2 clips on the IVC side on the adrenal vein, to me, are more than sufficient. There were suggestions in the past to me to apply hemoclip. I applied it on one patient in private in pheochromocytoma. The patient was a doctor, and I applied one titanium clip, and in front of my eyes that hemoclip came out. It just slipped out. That day I decided that I am not going to get into hemoclip business because veins are soft, and if that clip is not proper, it is likely to slip. Believe me, I spent completely sleepless night whether my titanium clip is going to slip. So that is what I would say, that use the correct size of clip. Ajay will remember, I had applied wrong clips in a cholecystectomy in a workshop, and both the clips had slipped. And that time Ajay had told me, if you don't use the correct size of the clip, and that has imbibed in my mind, so I'm extremely careful while doing adrenal clips.
Right. Any special tips for patient? Again, this is a question from the audience. Any special precautions to be taken for the elderly?
If the patient is fit for anesthesia and the tumor is functional and is going to correct this patient's perennial problem that is going to occur, I think one should operate on this patient. Yes, see, age does not matter. The disease matters. Like if at all the patient is unfit, cons will be still conserved by endocrinology. The patient will not come to you at all. But a pheochromocytoma with increasing requirement for control of BP is a patient who should take that risk to undergo surgery.
Basically, he's earned the surgery, so you have to refer it to him. Right. Another question, which because of your interest in retroperitoneal approach to the adrenals, do you think that there is a particular learning curve of the transperitoneal approach going into the retroperitoneal? Because our teachings here are to go to transperitoneal. What do you think is a sufficient number of transperitoneal adrenalectomies and then graduating into retroperitoneal approach?
See, in our first publication of graded approach as far as transperitoneal, first and foremost, let me tell you, transperitoneal is easier for any surgeon. That's the bottom line, because we have never seen retroperitoneum in routine surgeries. So that becomes a problem. Now, talking about experience, I think through our publication, we have already said, we kept on doing small cases, smaller size tumors, normovascular tumors for about 30. It's only then, and let me tell you, it is not out of our wish. When our endocrinologist felt that, yes, now Dr. Dalvi is able to do an adrenal properly, now I will give you a pheochromocytoma. Till then, they did not give me a pheochromocytoma. Okay. So to me, for a general surgeon who has not had experience in adrenalectomy first and foremost should take help. I'm not saying call me, I'm just saying take help. And second important thing is that otherwise go and see whenever adrenalectomy is being done so that you have a concept. All these edited videos look quite nice, but the environment in the theater, especially when you are doing pheochromocytoma, is the thing that you should feel. As far as retroperitoneal is concerned, let me tell you that we have done few. We went there, and when we watched Dr. Martin Walsh doing it in 15-20 minutes, it was worth watching a good movie. But when we came back and even to give position, which we had taken photographs, we had seen everything, was such a difficult thing. But let me give again credit to Dr. Rege. He managed to get into that position mode, trained the healthcare workers in the OT to give those positions. Now we have no problem. The second issue we had with retroperitoneal adrenalectomy was the ports. Getting into retroperitoneal was never a problem, but the port positioning and ergonomics gave us a lot of trouble. And the video that I've shown possibly is the third or the fourth one. It looks very nice, but I was struggling, let me tell you. With experience, we have managed to get a correct, this, the ribs come in your way and the trocars or the cannulae don't move the way you want. And then you start struggling. That is what is the problem with retroperitoneal adrenalectomy. I showed you the right side. Let me tell you, left side is even more difficult. It is more difficult because the adrenal gland is anterior to the kidney. So the trick in left side is to push the kidney down so that the adrenal pops up. And then you do dissection. So your one hand, left hand is left defunct, just pressing the kidney down. And your only one hand is working. And just imagine if a complication occurs, what is going to happen. Thank you so much.
Yes, President, sir, please.
Yeah, Jaideep, just wanted to come in. Congratulations, Dr. Dalvi. Excellent lecture. Excellent. Many junior surgeons are watching currently and learning. So, question for them: if somebody wants to start laparoscopic adrenalectomy, they should go left or right? Which particular tumor? What is the learning though?
See, this question has been asked so many times. It is a personal preference, let me tell you. Okay. Right, let's take the transperitoneal first. It is said that right is more difficult in literature multiple times. I always feel right is very easy because you are targeting only IVC, and if the liver retraction is good, there is no problem. On the left side, for that matter, you are actually looking at two organs. The splenopancreatic complex, which can become difficult to retract in spite of complete mobilization and lateral position. And if the position of the tumor is almost anterior to the aorta, even vision becomes difficult. So technically, as I said, prepare for an adrenalectomy by seeing your CT scan properly. Then both are equal according.
Yeah, thank you very much.
Retroperitoneal, I'm not in a position to give you any opinion because too many small cases I've done. And as I said, I'm still struggling. The last adrenalectomy done by Dr. Rege, he completed in 25 minutes without any help. So we are improving. Let us.
Yeah.
So I think Professor Dalvi, it was, as President Sir already mentioned, a really well explained talk on adrenalectomy. And I think the lessons that all of us have learned today is to probably look east as in E for the endocrinologist, A for the anesthesiologist, and S and T for the surgical team that you have. And without these components, you cannot do advanced laparoscopy and especially adrenalectomy. And I think for all the surgeons who are here to take away some pearls of wisdom from you, you've done complete justice to all of them. Thank you so much for taking out your valuable time today for this evening. And from all of us at IAGES, we thank you once again, and I shall hand over the proceedings to Dr. Kanagwal.
Thank you, Talvi sir. Thank you, Jaideep sir, for making this evening a real super intense learning part for all the practicing surgeons and the young surgeons together. I invite the President, Professor Sunil sir, to give his comments and then move on. Over to you, Professor Sunil sir.
Thank you, Kanagwell. Excellent lecture by Professor Dalvi, as always. He's a born teacher, and as he said, he taught for 36 years. But I assure everybody that teaching will go on for another 20, 30 years. He's a born teacher, and he cannot remain silent without teaching. Excellent lecture. Before we move on to another excellent lecture by another dignitary and faculty and past president, I just want to come in to congratulate and to thank all the IAGES members and their friends and other people who donated generously to IAGES COVID Task Force and IAGES COVID relief efforts. In last 5 weeks, since we started IAGES COVID Task Force, we have been receiving donations from all across the country. And with this generous donation, IAGES have been able to supply the goods for IAGES COVID relief from Mumbai to Madurai, from Jaipur to Jamshedpur, and to Gujarat, from Gujarat to Assam, and from Delhi to Kanyakumari. All the states were covered, and it was a pleasant experience, joy of giving. We all know how much we and our colleagues and our country has suffered in the latest pandemic. And IAGES has come forward and distributed a lot of relief materials to the needy people in the remotest of villages and cities. So I thank all the donors and IAGES members and the distributors who have come forward. Yeah, I would
President, I will just, before you, since you have taken up this topic, I've received a parcel of masks, which tomorrow I'm going back to KM Hospital. Thursday used to be my OPD, it is Dr. Rege's OPD. All these masks will be distributed to the patients, poor patients who usually visit KM Hospital. I will send you the images as they are taken. Thank you so much.
Thank you very much. I'll now invite Kanagwell to start the second lecture, please. Thank you.
Thank you, Dalvi sir. I know that you are to go to the another meeting. We kindly excuse you, and please feel free to go to the other meeting which has already started. Thank you, sir.
No, I will wait for Ajay to finish. I may not wait for questions.
Thank you, sir.
You learn from Ajay all the time. Something will come out, because I also give spleen lectures, so something will come out. Just not Palep talked about East. So I realized that some things can be learned. Thank you.
Thank you, sir. Thank you. It's our honor to have you continuously, sir. Then we move on to the next peak of importance. We have a very eminent speaker, our past president. I think he's been into the teaching profession more than 4 decades. I think he has seen both the extremes, the open surgery extremes and the minimal invasive surgery extremes. And may I have the honor of inviting the moderator, Dr. Meenakshi Sharma. Dr. Meenakshi Sharma has been graduated from the Medical College Nagpur with flying colors. And later on, looking back, she has been into various steps of advanced laparoscopic surgery. But I think her passion is a little bit on hernia surgery. And she heads the minimal invasive surgery unit at the Paras Hospital, Gurgaon. And she represents IAGES as the North Zone EC member. And she has been on various boards, FALS board, FAGS boards. And at this point of time, she has hosted FALS hernia, FAGS courses, and has been faculty to most of the IAGES courses on basic and advanced laparoscopic surgery. With that few words, may I have the honor of inviting Dr. Meenakshi ma'am to host the second half of the program. Over to you, Dr. Meenakshi.
Good evening. Thank you for a very kind introduction, and I'm indeed fortunate to be introducing my guru, Dr. Kriplani. Here in Gurgaon and Delhi NCR, we can never afford to miss any of his lectures or his programs, and you are spellbound in the entire duration of the entire course, whatever he holds or whenever he speaks. So as we all know, he's a past president of IAGES, a very passionate and a very kind teacher. He was the first one to organize the FIAGES. And sir, it's a very humbling experience to be, it's like a prayer come true to be listening to your lecture. And I'm always searching for your videos, as are the rest of the IAGS members. So requesting you to start with your laparoscopic splenectomy, sir.
Thank you, Dr. Meenakshi, for your very kind introduction. And, it is basically your kindness to say such good words. Dr. Sunil Popat, President IAGS. Dr. Ishwar Murthy, Honorary Secretary, IAGS, Dr. Kanagavel, very dear friend and convener, Dr. Abhay Dalvi, Chief Trustee and President of the ASI, Dr. Jaideep Palep, all other friends, delegates. It's really indeed a pleasure and an honor that I've been invited by the IAGS to talk on laparoscopic splenectomy. This is a surgery which has been improving over the last many years, and we have been interested in laparoscopic splenectomy from the very beginning. I bring you compliments from Fortis Memorial Research Institute, Gurgaon, where I've been working for the last 7 years. And spleen, as all of us know, is the largest lymphoid organ in the body. It functions. It's site for blood cell storage and quality control of the RBCs. Open splenectomy for trauma and hemorrhagical disorders has been in vogue for decades and maybe centuries. The first laparoscopic splenectomy was performed in 1991, and we followed and performed the first laparoscopic adrenalectomy in India at the All India Institute of Medical Sciences. So this was the first splenectomy we performed in 1993 at AIMS. So it's not like adrenal, which is a very small organ, which is 90% of the diseases are benign. It's easy to handle. Spleen is actually not an organ suited for laparoscopic surgery because it is a large organ. It is difficult to handle with fine laparoscopic instruments. It is very vascular with multiple big pedicles. It is friable, bleeds easily and massively. And if it bleeds, it is very difficult to control. Therefore, prevention is very important of the bleeding, particularly when the indications for splenectomy are thrombocytopenia and pancytopenia with its inherent bleeding tendencies. And in disease, it increases in size, vascularity, and friability, and therefore is more likely to bleed. Now, indications are benign hematological disorders, the commonest being chronic ITP. Please remember, chronic is important. The ITP should be there more than 9 months. It is the best indication because the spleen is normal in size, thrombotic thrombocytopenic purpura, hemolytic anemias like hereditary spherocytosis and elliptocytosis because spleen is keeping a quality control of the RBCs, autoimmune hemolytic anemia, thalassemia major and thalassemia intermedia, and hypersplenism. Other indications include trauma, which is the commonest but not so commonly performed by laparoscopy because of its problems, splenic cysts and abscesses, myeloproliferative disorders like acute and chronic myeloid leukemia, malignancies involving the spleen like myelofibrosis, Hodgkin's lymphoma, hairy cell leukemia. These indications are becoming less common with the advent of chemotherapy, with other malignancies like that of the stomach and distal pancreatectomy and splenic artery aneurysm. That's a case of splenic artery aneurysm that we handle by splenectomy. You can see a very large aneurysm lying in close contact with the spleen. Now, you can see that indications are with varied morphology, symptomatology, and pathophysiology. When you're doing laparoscopic splenectomy for trauma, you have to understand how to handle the extravasated blood around the spleen and handle it. In hematological disorders, the surgeon has to cope up with low platelet counts and low hemoglobin and hemolytic anemia. If you're doing the splenectomy for a cyst, you have to choose between ablative or can you preserve the spleen? Infections, pyogenic and tuberculosis. One of the worst type of adhesions between the spleen and the diaphragm. And diaphragm being a thin membrane, you can easily damage it because of the extensive fibrotic adhesions. And hypersplenism, where patient has pancytopenia, very large, vascular, fragile spleen, very difficult to handle. And it is sometimes can be a nightmare to handle such spleens. So this is one of the large, massive splenomegaly, which means more than 1500 grams. We call it massive splenomegaly. And this spleen, when you dissect them, this is the kind of splenic vein we are going to handle. And when the splenic vein dilates, it becomes thin-walled. It becomes more friable. It bleeds more easily. And being a component of the portal system, valvulus on the draining side, if it bleeds even a little bit, the smallest puncture will cause massive bleeding. So you must be prepared to handle such bleeding, such massive bleeding. So the commandments for laparoscopic splenectomy are optimal resources. Never take splenectomy cheaply, easily, simply. You should have optimal resources, manpower resource, experience and open laparoscopic surgery and splenectomy, thorough knowledge of the anatomy, its vascular pedicles and pancreatic tail, which actually decides whether the splenectomy is going to be easy or difficult, a good camera, instruments, the hardware. So you're good to have an optimal hardware resource, soft grasper to handle the spleen, sufficient ports, good exposure of the field, advanced energy resources, and then you have to have optimal infrastructure, like ability to manage severe intraoperative bleeding. So you should always have blood in the standby. And if you are handling a very large spleen, a very massive spleen, your blood bank should have adequate number of blood available so that if any mishap happens, it should not cost the patient his life. Second commandment, you have to preoperatively optimize the patient because the indications for splenectomy are varied. And in different situations, the preparation is going to be different. In ITP, the platelet count has to be adequate by preoperative steroids, vincristine, Deflon, or IgG. In hemolytic anemia, you have to correct the anemia. So also in trauma, you have to keep blood transfusions ready. If you are planning splenectomy electively, it should be vaccinated for encapsulated organism, pneumococcal, meningococcal, H. influenzae 2 weeks before surgery, or a subspecialty surgery you can give it after 2 weeks. Preoperative embolization has been given up, and radiology has no role in splenectomy except ultrasound to ensure that the patient does not have gallstones. Now, a word about platelet transfusion in ITP. We are sometimes called by the physicians in a patient of ITP, and when we reach there will be 10, 15, 12, 8 units of single donor platelet concentrate having been transfused without any increase in the platelet count. So please remember, in ITP, pre-operative platelet transfusions do not increase platelet because these platelets through splenic artery go to the spleen and then they are devoured by the spleen. Spleen destroys the platelet. If you have transfused platelets, these platelets survive only if the splenic artery is clipped. That means the best time to give platelet transfusion is after clipping the splenic artery at surgery. And if you have clipped the splenic artery at surgery, you are not going to require platelet concentrate because the platelet count is going to increase. Therefore, there is hardly any role of platelet transfusion in chronic ITP for laparoscopic splenectomy, and I regard it an utter waste of resources and money. And when you are doing laparoscopic splenectomy for ITP, you should be able, ready, willing, and prepared to do a laparoscopic splenectomy with a platelet count of 10,000, 5,000. You can see this patient, multiple ecchymosis, old ecchymosis, and don't fear because platelets only cause capillary oozing. And in laparoscopic splenectomy, with the current energy sources, it is not the capillary which is going to bleed. It is going to bleeding going to occur only from major vessels. So there's never any excessive bleeding with the current day energy sources, and you should not fear or hesitate in doing laparoscopic splenectomy even with a platelet count of 10,000, 5,000 and 2,000. This patient had a platelet count of 6,000. Third is patient position. Position is very important. There can be two ways to do the splenectomy: a full lateral or a hanging spleen technique, which is the French method. We prefer the 45-degree tilt with a sandbag behind the left lobe of the left rib cage. This is how the patient is at the edge of the table, not in the center. The surgeon faces the patient, and the monitors are on at the level of the shoulder. The loin is opened up by elevating the bridge, and this is not a 90-degree position, not an exact lateral position. The position is actually only a 50-degree tilt. You can see, you should appreciate that this is not a 90-degree. This is a sandbag here, and to make it further clear, this is the kind of 45 to 50-degree tilt that we require for a laparoscopic splenectomy through our approach. Now, the fourth commandment. The first step in laparoscopic splenectomy is, particularly when you're doing it for hematological reasons, search for accessory spleens. If you start dissecting, you stain the omentum, the gastrosplenic ligament, and you will not be able to find the accessory spleen. Then we take the splenocholic ligament. If you go for splenectomy in this sequence, perhaps we have realized that we end up doing a better splenectomy day by day. So after searching for the accessory spleen, the first handling is of the splenocholic ligament, followed by gastrocolic ligament, which includes short gastric vessels, then the splenic artery, and then comes the splenic vein and the pancreas. This is what you can interchange depending on the position. Remember, pancreatic tail decides the ease or difficulty of laparoscopic splenectomy, and depending upon how the pancreas and the splenic vein are disposed at the operating site, you will decide which one to take first. And the last one to take is posterior leaf of the lienorenal ligament. So an accessory spleen, it is most commonly found in the gastrosplenic ligament, in the gastrocolic ligament, around the splenic artery, splenic vein, tail of the pancreas, but it can be present in the small bowel mesentery and also in the pelvis near the ovaries. So do a thorough search. A leftover accessory spleen can be responsible for recurrent symptoms in ITP, and then therefore they should be looked for specifically. Radiology and radioisotope studies have no role preoperatively to locate these accessory spleens, because preoperatively they are very small. Once the spleen is removed, they start enlarging in size and then are responsible for the recurrence of symptoms. Now, the surgeon must know the anatomy of the splenic artery, because it is the most crucial thing. Splenic artery clipping or splenic artery occlusion is done in the initial stages before you go to the splenic hilum. This splenic artery is the largest branch of the celiac trunk, almost 10 centimeter long, tortuous. It is very important that it is tortuous. It makes it very easy to hold the artery with an atraumatic forceps, lift it and dissect underneath because of its tortuosity at the upper border of the pancreas. In normal health, it carries 5% of the cardiac output, but in massive splenomegaly, it can carry up to 15% of cardiac output. So you can imagine in massive splenomegaly how big this becomes. It gives branches to the pancreatic body also, not only to the spleen, dorsal pancreatic artery, arteria magna, and also to the tail of the pancreas. It is identified pulsations and not vision. If you try to see the artery, it is hardly visible, but the pulsations will give away the location of the artery, and it can be held, as I said, with a soft grasper and lifted due to its tortuosity. Now, the distribution of the splenic artery, it divides into 3 or 4 segmental branches, which in turn divide into multiple branches and enter the spleen. The blood supply can either be magistral, in which there is a long splenic artery dividing at the hilum of the spleen, and it can be distributed where it divides much earlier. So multiple branches go, and when we try to clip the splenic artery proximally, particularly in large spleens, then maybe you can miss one of the branches, and therefore you will not be able to de-arterialize the spleen completely. Generally, in a patient with a distributed pattern, there are notches on the anterior border of the spleen. You can see these notches, and if you see the notches, you can be reasonably sure that this is a distributed blood supply. Another fact is that this arterial supply of the spleen is truly segmental in nature. There are no collaterals. Occluding one artery will lead to infarct of the spleen, and you will see the color change on the splenic surface. Now, this helps the surgeon tremendously when he is going to clip the artery. So, the spleen must be completely de-arterialized before touching the splenic vein. If you take the splenic vein first, there will be tremendous oozing from the surface of the spleen, and you won't be able to finish the splenectomy. So, vein is very easily visible. It is very large. Artery is not visible. You have to look for the pulsations of the artery. So when you open up the gastrointestinal sac, it is very tempting to go for the splenic vein first, and that is what the surgeon should always avoid. Never take splenic vein before taking the artery. You can see here that this upper part of the spleen is de-arterialized. The lower color is normal, and you can see here this is a distributed supply, the notches here, and a segmental branch is entering the spleen. And you can see now, once the artery has been completely clipped, the entire spleen becomes blue in color, and before you touch the splenic vein, you must make sure that the spleen has been completely de-arterialized, the arterial supply has been blocked. This is the surgeon's utopia. A wish that the tail of the pancreas is away from the spleen. Generally, the tail of the pancreas is within 1 centimeter to the hilum of the spleen, and you have to struggle to dissect the artery, the vein, and the tail of the pancreas. Tail of the pancreas is the most crucial structure, and injury to the tail should always be avoided. Generally, when we give the position, the spleen falls further because of its weight and comes closer to the tail of the pancreas. Therefore, the proximity makes the surgery more difficult. When you are dissecting the artery and the vein, the closer you go to the hilum, the closer these structures are to each other. Therefore, always try to dissect the artery as far away from the hilum as possible, so that the vein is little away from it, and therefore you do not damage the vein while dissecting the artery. And this is how the spleen is removed by finger fracture, normal spleen with small pieces. Virtually, it's like a chura of the spleen which is done in a bag, or you can morcellate it. When you are removing a large spleen, then we give a fenestrial incision and we remove it. So let us see a normal size splenectomy. So these are the ports: 10 millimeter port at the umbilicus, 10 millimeter port for the right hand in the midclavicular line, 5 millimeter port in the epigastrium for the left hand of the surgeon, and 5 millimeter port for the assistant who is going to retract the spleen, give the proper position, and so that the organs are visible clearly. And sometimes he will hold the spleen with a soft grasper and lift it. The first organ to be mobilized, commandment 4, is the splenic flexion of the colon. It comes in the way, and you divide the splenocolic ligament first, so that the splenic flexure goes out of the harm's way. Particularly in large spleen, the colon is more closely applied over the spleen and also on the medial surface. So the colon should be safeguarded first, the splenic flexure. The next step is you open up the gastrosplenic ligament widely, going up to the upper border. At the upper part, the gastrosplenic ligament is more short, and you may actually have to divide it layer by layer. So you divide the gastrosplenic ligament with a containing short gastric vessel, and the lesser sac is widely opened, and you see the splenic vein tempting you, inviting you to take it. But you must look for these pulsations of the splenic artery above the splenic vein. You can lift the peritoneum and just divide this peritoneum with an energy source, and because of its tortuosity and more length, once you incise the peritoneum, the splenic artery pops out and then presents itself to you because you are going in the right direction. So this is how the splenic artery pops out. So you can hold the splenic artery with a grasper, with an atraumatic grasper. The direction from the right hand is very suited upwards. So if you stay close to the splenic artery, this is a lymph node or an accessory spleen, then the vein will not be damaged. So lift the artery, gently increase the window. Generally, the direction of the instrument is away from the splenic vein and you will not harm it. So apply a clip on the splenic artery, 2 clips on the patient side, 2 clips on the specimen side, and you divide the splenic artery and look for the color change, which takes a few minutes. So till the time you are looking for the change, you can start dissecting the splenic vein, and you see the spleen is becoming darker here, and you are in the meantime dissecting. It takes a little longer. This is the pancreas, and now because this artery has been clipped, we have nothing here. So gently, carefully, diligently, you start dissecting the splenic vein, and now you can see the lower spleen is completely dark, but the upper portion in the spleen is not still very dark. So we know that while we are dissecting the spleen, no, it is completely dark. Sorry. This is, you can see the upper pole to the lower pole, it is completely dark. So we know that the splenic artery has been taken care of, and now the splenic vein is dissected and then clipped. You can see how the spleen has changed in the color from the upper pole to the lower pole. So now, once the spleen is dark, and only when the spleen is dark, the splenic vein is divided. You can see wrinkles on the splenic capsule. And now, once that is done, you have to carefully safeguard the tail of the pancreas by dissection close to the splenic capsule at the splenic hilum. The pancreas is pushed away from the spleen, from the splenic hilum, without causing any injury. So here we are dissecting absolutely on the splenic capsule. And when we are finding it little difficult, because the spleen, the pancreatic tail is not so easy, you can see there's proximity of the pancreas to the spleen. We are trying to dissect it and create more space. Pancreas should not be traumatized at any cost. And you can see this is the pancreas that we are dissecting. So when we cannot dissect the pancreas, we decided we will go and divide the posterior leaf of the linear ligament. So this is a way out in a situation of a difficult dissection of the splenic hilum, that you divide the posterior leaf of the linear ligament. You are pushing the retroperitoneum posteriorly, and you can see this is the Todd's fascia. You can see the Todd's fascia. This is the absolutely avascular plane. There's nothing coming, no vascular structure is coming here. The more and more you divide the posterior leaf of the linear ligament, you can lift the spleen and increase the distance between the splenic hilum and the tail of the pancreas. Don't divide it completely. Leave a little part of the linear ligament attached. Otherwise, the spleen will start wobbling and will be difficult to control. You can see how avascular this part is. And now you can see that the splenic pancreatic tail is much widely, much clearly visible. We are also disconnecting this little tissue superior to the tail of the pancreas. And now you can see we lift the spleen. This is the tail of the pancreas. By dissecting the linear ligament posterior leaf, we have created more space and we are able to retract the spleen more, and therefore we can now divide this areolar tissue, safeguarding, clearly seeing the tail of the pancreas. This is the splenic artery and this is the splenic vein. Now, once we know there is no other attachment remaining to facilitate our delivery of the spleen, which is a large organ, we want to bleed the spleen. Artery has been clipped. So if you cut the splenic vein towards the splenic side of the venous clip, then all that sequestrated blood in the spleen will come out and make the spleen smaller. The spleen will shrink in size, and it will be easier to remove the spleen. So here we are holding the tail of the pancreas. This is the splenic vein opening that we have divided without applying any clip, because there's a clip here and there's a small little bleeding. Since the tail of the pancreas is in our complete control, you can apply clips and take care of this small little bleeding. And then the remaining little flimsy attachments we had left, because we did, and you can see the blood dipping, the sequestrated dark venous blood dripping from the spleen, making it smaller in size, and then that makes your extraction of the spleen easier. So all these small little flimsy adhesions are divided. which were helping us in retracting the spleen from the pedal of the pancreas. The retroperitoneum is looked. Any small oozing point is cauterized, is taken care by energy source. This is the tail of the pancreas. This is the artery and the vein. This is the splenic vein. And you can see this is the clip on the splenic artery. And this is the entire operative field, which is clean, neat, and bloodless. So that completes the laparoscopic splenectomy. And now the spleen needs to be put in a bag and then fractured with a finger, do a thorough wash. Some people believe in injecting local anesthetic into this raw area to decrease the post-operative pain. Now, laparoscopic splenectomy for a massive spleen, which is a totally different ball game. And you can see this is the large spleen coming right up to the umbilicus. Your ports have to be little farther away from the spleen so that you have enough space to handle this spleen. You cannot hold this spleen, you cannot lift this spleen, you can only retract this spleen by this grasper from the assistant. The spleen is larger and heavier than the liver. The spleen weighs more than 1500 grams. So the only thing you can do is to lift the anterior border of the spleen to expose the gastrosplenic ligament, again, which is divided widely after taking down the lineal ligament. The splenocholic ligament. I repeat all this. I'll only show you here the special situations of large spleen. The splenic artery is very large. It is very easily visible and it is thick walled. It is more easy to handle than a normal splenic artery because it is carrying now 12 to 15% of cardiac output to the spleen. The splenic vein is also very large. So the splenic artery is easily picked up and is clipped, expecting that the spleen gets dark in color, congested, de-arterialized. And you can see we have achieved this in the lower part of the spleen, which has become blue. And this is the clip applied to the artery. We are further cleaning this area and cleaning up the branches. And then dissecting. This is the splenic vein coming up in view. These are the branches of the splenic artery. We have clipped the artery here and we'll again divide the branches here to be doubly sure because it has been a very, very big splenic artery. So you can see this part is a big vein here and this spleen is still not very dark color as compared to the lower pole. So we know that there's some more, you can see the color, this is not as dark as the lower pole. So we know that there is another branch of the splenic artery which we have not found and which needs to be taken. So you can see a big segmental branch of the splenic artery and a big tributary of the splenic vein here, massive. This vein is almost 7 to 8 millimeters in size. So you have to handle it very carefully, gently. This tributary of the splenic vein is pushed aside. The splenic artery branch is dissected for a sufficient length. And then it is dissected circumferentially and will be clipped. And we will hope that after clipping this, the spleen becomes dark in color. So we dissect. So this is the branch which was going down the splenic artery. This is the branch which is going up. So we clip it again closer to the spleen and then closer towards the first clip that we had put on the artery. And you can see there's almost a 4 millimeter branch of the splenic artery, and that now you can see that the color is becoming darker. It takes about 10 to 15 minutes because this part has already been clipped for a long time, but you can see wrinkles here appearing on the splenic vein showing that this has been de-arterialized, and in a little more while it will become dark. So few more branches of the splenic artery coming. Now because the spleen has been devascularized, the bleeding after dissection in this area will be low. So the spleen artery now is completely disconnected and put on one side. And now we don't want to handle this almost 15 to 18 millimeters of splenic vein because it will be very friable, thin walled. So we generally in very large spleen take the tributaries of the splenic vein and clip them one by one rather than clipping this main splenic vein which is very large in size. So we have started clipping the tributary here. Clipping this tributary gives more mobility to the splenic vein, and so you can go circumferentially along this vein at a more distal point, which otherwise you will not be able to go when these tributaries are not divided. So this splenic vein we don't want to clip. There's no size of clip which will take this. You can see now things are becoming darker in color. There's no clip which will take this dilated, thin-walled, friable splenic vein. So this is ligated, and once you ligate, because the splenic vein size becomes narrow, then the clip application becomes easier. This is the tail of the pancreas, again, which is being carefully being separated, and then this is the tie on the splenic side of the splenic vein, which will complete the vascular isolation of the spleen. And after that, the splenic vein will be divided. In such large spleen, we do not have the courage, to make the spleen bleed just by chance. Even a small little artery has been missed. So the splenic vein is ligated on this side, and then it will be divided, and then this spleen will be delivered through a phenecyl incision. Now, laparoscopic surgery of the spleen is not all about splenectomy. There are surgeries in which we conserve the spleen, and the commonest indication for conserving the spleen is a splenic cyst. But not all splenic cysts you can safeguard the spleen. You can see this is a very huge, large splenic cyst. Very little of the splenic parenchyma left, but it's not worth preserving. A still larger spleen, very little parenchyma left. And this is a spleen at the center of the spleen, hilum of the spleen. So all the vessels, arteries and veins will be splayed on the CT. They'll be splayed on the splenic cyst. So again, this central cyst is not a good idea to do a laparoscopic spleen preserving procedure. This is an ideal indication, though the cyst is large, but it is on one pole, the superior pole of the spleen. And in this patient, this was a 17-year-old girl, and we did a splenic preservation surgery. We just marsupialized the vein, the cyst, and this is how the surgery went. You can see this large spleen. We had done a serology for hydrated, which was negative, but when we saw this color, we became a little suspicious. So we are aspirating the cyst, and the cyst will get, this is the nature of the fluid that we aspirated. You can see this is little dirty in color, but this whiteness, made it a little suspicion if it not be hydrated cyst. So we put after we completely aspirated the cyst, we put betadine gauze pieces, so that if there's any spillage, it should be on the gauze pieces. And then after putting this, we filled the spleen with povidone iodine. You can see again the cyst has been distended. So there's a povidone iodine has been filled on the spleen, and this is distended. And after a contact time of about 9 minutes or 10 minutes, the cyst is again aspirated. The povidone iodine is again aspirated to collapse the cyst. It is just as an extra precaution because of the color of the capsule of the cyst. And then we open the spleen, open the cyst using an energy source. And this is a typical appearance of a simple cyst. You can see the trabeculation. There is no ectocyst, there is no daughter cyst. And then carefully, we started marsupializing the cyst wall. But here you can see a little bit you go on the splenic side, and then there is bleeding here. So this bleeding, you have to be very careful. You don't go into the splenic parenchyma, but stay on the side of the capsule of the cyst so that the bleeding does not occur. So you can see this. And this, the cutting on both the sides, from the posteriorly and from anteriorly, this splenic cyst is completely removed. So the cyst is disconnected. Hemostasis is checked. The spleen is put in a pouch. The cyst wall is put in a pouch. The gauze pieces are also placed in a pouch. Check for hemostasis anteriorly and posteriorly. Do a good wash. Remove all the debris, the blood that were present there. Put a Surgicel for added hemostasis. Put a drain. and then this pouch is removed so by enlarging one of the 10 millimeter ports in the mid-clavicular line. The complications that can happen during surgery are bleedings of the splenic vessels, injury to short gastric vessels and stomach, injury to the pancreatic tail, injury to the diaphragm. Sometimes the injury to the stomach can also occur when the spleen is very densely adherent to the greater curvature of the stomach, and in that case, in some cases, we have divided the greater curvature of the stomach using a stapler so that part of the stomach wall comes with a specimen. Injury to the left colon, particularly in large spleens, pulmonary complications, subsplenic collections and abscesses, and OPSI, for which prophylactic measures should be taken. So the 10 commandments for laparoscopic splenectomy include optimal resources, skill, hardware and infrastructure, pre-op optimization, good position and ports, search for accessory spleen, first take the splenocolic ligament, then gastrocolic ligament with short gastrics, then splenic artery, tail of the pancreas and splenic vein, and last posterior leaf of the lineal ligament is to be taken. This is the team at Fortis Memorial Institute, Gurgaon. Thank you very much.
Thank you, sir. That was a totally exhaustive and complete coverage of the lab procedures in spleen. I have just one question. What do you suggest for the operative management of a laparoscopic treatment in a pseudocyst of the spleen following pancreatitis?
Cirrhosis of the spleen?
Yes.
I'm sorry, I have never heard, never tackled a cirrhosis of the spleen. We have seen cirrhosis in the spleen because of trauma. These are the cysts which are containing blood because of the trauma, and we have rarely done splenectomy for them. But I think that cirrhosis of the pancreas are in the lesser sac and not in the spleen. I'm sorry if you have handled it. I'll be very happy to know. But we have not tackled any cirrhosis of the spleen because of pancreatitis. There have been cyst because of trauma which you have handled, which look like the cyst, but they were not true cyst. When they said that they had no true lining. But we have never tackled any cirrhosis of the spleen because of pancreatitis.
Ajay, I think what she is trying to ask you is traumatic cysts of the spleen, which are chronic.
Yeah, we have handled that.
And they come under classification of a pseudocyst.
Yeah,
that is somebody trying to ask you.
Spleen, but not cirrhosis in pancreatitis.
No, not pancreatitis. Yeah. What she's trying to ask you, or somebody's question is a cyst existing in the pancreas because of trauma.
It doesn't have a lining. It is generally because of
I agree. I fully agree. What she wants you to elaborate is the same thing which you call as pseudocyst. Just tell how to go about it. It is partial, just evacuation and nothing else that is required.
Yes. If it is not infected, then you will end up with a splenectomy. But if it is not infected and not severely symptomatic, we have seen these cirrhosis varying from 3-4 centimeters in size to 10 centimeters in size. When they are large, when they are bulky, when they are causing pain, then you can even have an ultrasound guided aspiration and see if you can empty them and they do not refill. If they do not refill, the story is over. But if they refill, then they will need to be tackled by surgery.
Absolutely agree with you. Absolutely agree. Yes, Popat.
Excellent lecture, Dr. Kriplani, as always, and you covered all the steps very nicely. At our institute, we always tell our fellows to ligate artery and vein first before applying the clips. And you also showed that on the vein. And any experience regarding use of stapler? I know you are not using stapler mostly, but any experience?
Very long back when we started splenectomy, and when we did our first laparoscopic splenectomy, harmonic was not there in India, right? So at that time we were using bipolar energy sources, and staplers came into vogue before harmonic. So staple splenectomy is a technique which we employed very rarely. I remember, I think we did 2 cases with stapler in which it makes the job very simple, very easy. You mobilize all the ligaments, the splenocolic, the linorenal, the gastrosplenic, and then you lift the spleen up, locate the tail of the pancreas, and over the vessels you apply a stapler, which is white cartridge. Even if your staple happen to bite the tail of the pancreas, you really do not have to worry, because while it'll cut the pancreas, at the same time it will staple it. So it is a very simple way of doing laparoscopic splenectomy. Some surgeons do this, but I think we prefer to do it by harmonic, because it can be done only for small spleens. It can't be done for large spleens or even moderate size spleen. Splenomegaly is defined as a normal size spleen. Then we say moderate spleen when the spleen is more than 500 grams, and massive spleen when it is more than 1500 grams. The normal spleen size being 150 grams. So in a small size spleen, you can do a stapled splenectomy, which is a feasible option. Mobilize it widely, completely from all 3 ligaments, and then lift the spleen, and then fire a stapler, and the job is done.
Yeah, okay.
But you will require more than 1 stapler, so it becomes very expensive, and you have to be extremely careful that when you are planning to fire the stapler, you should not use any clip in the splenic hilar area, because if you applied clip before and then you fire, then the stapler will not fire and you will be in trouble. So make sure that if you fire the stapler, you should not use any clip in that area.
Yes, excellent. Yes, Abhay.
Michel Gagnère was the first one to describe the posterior approach to splenectomy using stapler technique. And I used it once and it misfired, as Ajay exactly said. It misfired, led to conversion. It is only possibly out of whatever splenectomy I have done, one of the reasons for conversion, because there was panic at that time. And I was sponsored by this company to fire this stapler. And I did that. Maybe I made a mistake in stapling. I don't know. But it led to convergence. Luckily, patient survived. So posterior approach is very nicely described in literature. Go on to the net, find out it exactly what Dr. Kriplani said. Mobilizing everything, and the spleen just hangs on the pancreas. The claim made by Gagnère is very simple, that it leads to lesser pancreatic tail injuries. That is his thing in BJS, if I'm not mistaken. I have read it extensively. But don't try to rely on technology, rely on yourself, what Dr. Kriplani is trying to tell you, and tell all the audience. Rely on yourself, do what you know to do the best. I hope Dr. Kriplani agrees.
Oh yes, 100%, Abhay. And because if you try to find out an easy way, surgery is not to find an easy way out. Because if you do not do your dissections in smaller cases, in simpler cases, from simpler cases you learn, and this learning you apply on the more difficult cases. So if you do not do proper learning from simpler cases, you will not be able to cope up with the more difficult, more complicated, larger splenomegalys. So always increase your skill, increase your expertise. The most important thing is understanding of the anatomy. In that area, there are very few structures, but they are interdigitating with each other. The splenic artery, the splenic vein, and the tail of the pancreas. There are only 3 structures there, after putting the colon aside and dividing the short gastrics. So you try it, when you're doing simpler case, you learn how to handle these smaller organs so that you can apply them and do more and more difficult cases. You do moderate splenomegaly and then you use massive splenomegaly.
Thank you, Dr. Kriplani.
I agree with Ajay. It's not only anatomy, but including pathologic anatomy, which causes changes. And the surgeon has to decide what to use when. That is extremely important. And it comes with experience, or maybe complications that you create, or whatever it is. I hope Ajay agrees. I don't want to intrude too much on his talk, but these are the things which I've learned from him also.
You see, you learn from your difficult situations. You don't learn from your easy situations. When you're doing an easy splenectomy or an easy LME, everything looks good. It is your difficult situation when you had a problem, when you are not able to locate the branches of the splenic vein, or you are not able to find the tail of the pancreas, particularly in a obese patient, that you start thinking how to handle this situation. So you don't learn from your simple cases. You learn from your difficulties. You learn from your mistakes, and you learn from your complications.
And let me just tell you, just let me complete it. Sorry. I respect him. So I just want to say, I've got two cars, right? One is automatic and one is geared car. And I've been using an automatic car last whole year. Whenever I sit in the geared car, I forget to press the clutch. This is what happens to a surgeon when he does not prepare himself for a particular surgery. Then the car falls flat. That's exactly what I'm going to tell. So Dr. Prem has given a wonderful lecture on difficult situations, etc., etc. I congratulate him for this. I hope I have the permission to do that. Anyway,
yeah, you have all the permission. One more interesting thing, Dr. Kriplani. In your slides, you made it very clear that it is mostly elective surgery, elective splenectomies we are doing laparoscopically. But now, even in trauma cases, we are putting more and more laparoscope inside. So, any experience of putting a laparoscope inside ruptured spleen?
You see, Sunil, I for the last 20 years, or maybe say 25 years, 1990, 30 years, my team has not allowed me to come for emergency. You see, they have been so passionate, and they say your whole day routine is so busy, you are not allowed in an emergency. So once I went for an emergency, and my associate told me, sir, you go back. Go sit, have a coffee, and go back. So actually, my team has not allowed me to do emergencies, and all these splenic trauma patients come in an emergency. Second thing about splenic trauma is that many times these patients are unstable. If the patient has a splenic injury, the protocol now has become to do a CT scan, observe the patient. If the patient is stable and he has no other visceral injury, you are not going to do anything. You are going to observe him. You are going to operate him only when the bleeding is massive, he's hemodynamically unstable, his blood pressure is falling, his pulse rate is rising. And I think in that situation, it is better to do a quick open splenectomy than to do a laparoscopic cholecystectomy.
Absolutely, absolutely. That's what the take-home message I wanted.
In a middle situation, perhaps, if the patient is stable till the next day morning, and then you have a doubt as to you want to, it's a slow bleeding, and you want to do some, hemostasis of the spleen. The CT has shown that there's a tear, and you want to put either the Surgicel, or you want to mop up the blood, or you want to put Tissile. If the bleeding is slowly and continuously increasing, I think Tissile has become a very important adjuvant in our surgical hemostasis in the OT. Then perhaps you can do, but such cases are very uncommon.
Abhay wanted to say something.
Yeah, see, American Society for Trauma has clearly given 5 things about splenic tear. 1, 2, 3, 4, 5. 4 and 5 lead to shock. They require emergency exploratory laparotomy and should be managed by open surgery. 1 and 2 are completely conservable. They are stable, have to be managed either in ICU or in ward. It's stage 3 where it's given capsular tear greater than 5 centimeters, etc. I'm talking of isolated splenic injuries. And there was a paper which was published from South India on laparoscopic splenectomy in emergency situations. That also now has been vetoed out by American Association. These patients who require very close observations have 2 modalities. Number 1 is emergency splenic artery embolization and observe in ICU, or a laparoscopic treatment. This is the stage as of 2021, which is stated by American Association. As I stated in my lecture, Dr. Pinky Thapar was the person who possibly has done the first emergency splenectomy for trauma, and I have that video with me. It's nothing different from a splenectomy except that there is lot of staining because of blood that takes place. But as Ajay has already said, pulsation of splenic artery, as I see that video, allow you to clip it, which is same thing as embolization. So I think it is a surgeon decision which has to be taken as to isolated splenic trauma, which occurs in 60% of the cases, to take a decision what is to be done and whether the patient can be saved of any sort of intervention except embolization. Thank you.
Abhay, in the olden days, when we used to do open splenectomy as a mandatory situation in trauma before the considered treatment of spleen pain, we all are aware that when you operate for trauma, there's blood in the lineal ligament, there's blood in the retroperitoneal area, the tail of pancreas is difficult to define, the chances of injury to the pancreatic tail are there, and in fact the patient may have a coexisting pancreatic tail injury because of the trauma, which you are not able to identify during laparoscopic surgery because of the staining, and subsequently it will be entered in your complications of laparoscopic splenectomy while it is none of your fault. So for these reasons, I would rather say that laparoscopic splenectomy trauma has very limited role.
Ajay, I completely agree with you. For people who are trying to learn, I remember during my resident days, I've done 6 traumatic splenectomies. That time there was no laparoscopy in a day, and my lecturer penalized me from throwing me out of the theater for not informing me. These are some anecdotes which I can share. Trauma and laparoscopic splenectomy is not the thing which is for anybody who is not trained at all. Don't get into it, as Ajay is saying.
Thank you. Yes, Meenakshi.
I think we have one more question, which is when performing cytokine ELISA, when is the best time for spleen removal?
When performing?
When performing cytokine ELISA, when is best time for spleen removal?
Can you elaborate on this question if you understand it?
I have not understood it either. This is not
the question. If you can elaborate, I'll answer it.
This is a question from the audience.
Yeah, but
whatever it is, the audience has quickly gone into Google, asked for something, and just posted a question. That's my response to protecting both of you all.
I think Ajay clarified very clearly regarding ITP, and I think credit to Ajay, his laparoscopic splenectomy video on YouTube has got more than 50,000 viewers, and that is, I think, highest among all the IAGES faculties for a single video. So kudos to you, and I think you can still elaborate little bit on when you operate in ITP. And you clearly said that 2 weeks after your vaccination. You also clarified regarding the platelet count, it has nothing to do. So I think it's mainly people are afraid regarding when to go in cases of ITP.
I think that's a beautiful question, Sunil. We get so many calls. ITP patient is admitted under a physician, and then we are called that now we have done everything and the platelet count is not rising. They have given steroid, they have given vincristine, they have given platelet transfusion, and either they have given IgG, which physicians are very happy to do. Our physicians, I have worked in 3 different hospitals, AIMS, Apollo, and Fortis. Everywhere the physicians are very happy to use IgG because they said, we will give you a rise platelet count so that you can operate easily. I have tried to explain them that a drug worth 2.5 lakh rupees costs more than what my surgery will cost, and it gives me no added comfort whether I operate at a platelet count of 10,000 or I operate at a platelet count of 1 lakh or 75,000. Remember that the bleeding in cases of ITP is capillary oozing. They're small capillaries. which are oozing, which you are very effectively sealing with the current day energy sources. So never be unusually scared in going for a platelet count of over 10,000. We know from our experience in dengue that physicians do not give platelets below platelet count of 20,000. There is no added risk to the death. We used to classify purpura as two types: dry purpura and wet purpura. Dry purpura, when the petechiae are occurring under the skin, and this purpura is very innocuous. It is not going to lead to life-threatening complications. Wet purpura, where the patient is bleeding from the mucosa, from the gums, from the urinary tract. This is the purpura which can bleed in the brain and which can cause, death. That is the only reason why in purpura one can have death. So wet purpura we always take more seriously than dry purpura. We tend to operate earlier, and if a wet purpura is there, then maybe I will say that I'll operate earlier. Otherwise, giving platelets has no advantage at all except the cost incurred by the patient and taxing the resources of the hospital which are going to make platelets. The single donor platelet concentrate are very expensive. They need manpower, they need energy. Only drug needed preoperatively is steroids, which will raise the count. If the steroids are not able to raise the count, give vincristine, Teflon. Generally, if the patient comes to us, we treat the patients ourselves. But quite often, more often, 75% of patients will go to the Himalayas or to the physician, and then they prepare the patient. And it is very sad that either they have given the IgG before our going, because the effect of IgG lasts only 4 weeks. And there have been occasions when they have called us, they have given 2 cycles and one patient 3 cycles of IgG, which is sometimes, our hearts really bleeds for those situations. So don't give IgG. It is cheaper, more effective. I have never seen a platelet count not to rise after splenectomy. Never. Sometimes after immediate rise, it may come down. And the shortest time in which the platelet count has come down was 12 days. But generally the response is sustained. So a patient after laparoscopic splenectomy with a platelet count of 10,000 will never die of post-operative bleeding. Be very clear about it. After splenectomy, the counts will always rise, whether early or late. We call 2 types of responders: fast responders and slow responders. Fast responders are when you send a platelet count next day morning, you see a rise in the platelet. There are some patients which are slow responders in which you see the rise in the platelet count in 4 days, 5 days, 6 days. But you always see a platelet count rise. It never happens that the platelet count will not rise. The duration of response varies from person to person, but a patient will never have post-operative hemorrhage after laparoscopic splenectomy just because his platelet counts were low.
Great. Thank you very much, Jay, for clarifying the doubts. And with this, we'll have to conclude this session. And I must thank my dear friend and Chief Trustee Abhay Dalvi, and past President, and our dear friend and faculty forever, Dr. Ajay Kriplani, for enlightening all the people who have joined tonight. I will ask Kanagwal to take this session forward. Yeah.
Yes, Ajay sir.
Abhay is there?
Yes,
It was a privilege that you stayed for the lecture. I feel privileged.
No,
Despite your assignment somewhere else.
I have always learned from you. You are senior to me.
I feel honored.
And one thing which was not, you are BC Roy awardee, so I have highest respect for you. And
really a pleasure. I feel privileged and honored by your staying here despite your other assignments somewhere else.
No problem. I have convinced them, though I am the president of ASI, somewhere down the line, I have my, things towards IAGES. And if IAGES thinks that I should be recognized, I will there be all the time.
Thank you, Fred.
Thank you. Thank you. Yes, Kanagwal.
Thank you, sir. It is a pleasure to have twin treats in the same evening. Thank you, Dalvi sir. Thank you, Kriplani sir. And it's adding to the feather on the cap. Jaideep and Meenakshi ma'am had a wonderful moderation. Thank you, Sunil sir, for bringing twin treats this evening. I now request our Honorary Secretary, Dr. Ishwar sir, to take over for vote of thanks.
Thank you, Kanagavel. My dear friends, ladies and gentlemen, I'm sure you all agree with me what a wonderful academic feast we had today. I think this is yet another blockbuster thanks to President and our convener Kanagavel. We had two great lectures, one from the team based.
You are muted, Ishwar. Yeah.
Thank you, Kanagavel, and thank you, President, for giving me the opportunity to see these two wonderful lectures today, by one from the team West Zone, by the best of adrenalectomy from teacher par excellence from the West Zone, Dr. Abed Alvi, working with the team East as elegantly described by Dr. Jaideep Polly, the team East, endocrinologist, anesthesiologist, a good skill and mindset, and of course with his own best of team. Well done. I really enjoyed the lecture, and it takes me 30 years ago when I watched adrenalectomy done by Michael Brand. I think he is in St. Louis, and he was describing. He also said the right adrenalectomy for an experienced surgeon is easier than the left one. That again clearly mentioned with all the tips of how to tackle the adrenal vein. I think a marvelous lecture, Abed. We really enjoyed all the tips you have given us today. And of course, the next one is Dr. Ajay Kriplani, the team North, with the pearls of wisdom with regards to the lab splenectomy from the North Star of IAGES, Dr. Ajay Kriplani sir, of course with the upcoming academic star, our VP North Zone, the moderating officially by Dr. Meenakshi Sharma. I think we had both are good, and our hearts are with you, and we have sent you the certificate of appreciation. Please accept the certificate of appreciation from our president and from our IAGES office for both of you. Thank you, moderators, for keeping it. And there are a couple of news for all the viewers and all the IAGES members for today. As you all know, already there are 400 plus members have been benefited by this online course because of this raging COVID pandemic. Online FAGS and online EFAGS, both are there. Please join. If you haven't joined, just going and clicking to the IAGES website. And also, this time, probably with the next 2 months, with the fading away of COVID, we'll be starting our on-site programs. But before that, you can also join our oncology online also. It is also available. As we can see, we have a very, very energetic, enthusiastic team FAGS by Zamir Basa sir and team EFAGS from Govindaraj, Satyapriya we have, and I'm sure we are looking forward for yet another wonderful IAGES 2022. And thanks for all your patronage for 2021. I'm sure we have a better, bigger, and brighter IAGES 2022 in very near future. And I'm sure the last 3 weeks, thanks to our dynamic president and also Zamir Basa, we have been collecting, distributing, donating across the country, thanks to all our EC members, with the 3 motto of taking care of our own COVID warriors, with giving them N95 masks and giving them who are all cared at home by the home quarantine kit with the pulse oximeter, and very sick people, we are supplying them with the oxygen concentrators, and we had a very good IAGES and Jeevani inaugural function, and thanks for all of you who have joined there. And I'm sure it is very, very gratifying to see people are really happy to have it a free rental from IAGES. Such concentrators are going for across the country. Gandhi Bhaskar Rao himself has donated 10 oxygen concentrator, Saindev Dasgupta 5, IAGES 15 we have. So we have a 30 oxygen concentrators, thanks to all the people in IAGES. And here are all the glimpses in the last few days. I'm sure you might have seen from the last our things, Jaideep, his own style, and Sunil Kumar in his own region, and Madhuprakash Karanbal giving all the things you can see, and Aruprabha Far East. So we're reaching nook and corners, and more recently, as hot as today morning, our president himself donated kits, the home quarantine kits, to these places in near Ahmedabad. So thanks you all, and thanks I'm sure it is very, very nice to work in the central office to try to channel all these distributions. Very, very gratifying in this middle of crisis. We are able to be of some help. I'm sure every help you are going to render towards this is going to be wonderful. To the COVID task force, by either donating by net banking through the numbers, I'm sure you can see it in our website also, or easier thing would be just keto.org. You can go in, whatever amount it's while we have collected 30 lakhs, we have distributed already 27 lakhs by means of all these goodies so far. It is one of the largest contribution by one of the largest academically vibrant, socially responsible association. I'm sure all of us are already vaccinated, remain safe. I'm sure we all live positively with the better days ahead. Jai Hind. Thank you very much. Bye-bye.
Thank you, Ishwamurthy. Yes, Ajay.
President sir, it was so heartening to hear our honorary secretary enumerate so much wonderful work done by the association under your guidance. It was just out of there since you mentioned about my YouTube channel. When you asked me to talk on laparoscopic splenectomy, all the videos that I showed today are totally different from what they are on the YouTube channel.
Yes.
I made on because of your commandment, specially and specially for this prime time.
Thank you. Thank you very much. Thank you, Abhay. Thank you, everybody.
Thank you, sir. Thank you, everyone. And we look forward in the coming next fortnight with more exciting program. Thank you, Docplexus, for the flawless platform. Thank you.
What do you mean more exciting?
Sir, don't you think don't you think today's program was more
What can be
exciting?
more exciting than Abhay Dalvi and Kriplani?
It is the same way that each president of the IAGES has done better than the past one.
Yes.
So let him say that. I think he's right to say that.
Okay. I agree with you. I always agree with you. There is not a
Thank you, sir. Thank you, sir, for saving my day. So I'm sure the intensity of the prime time is going up and up by the week. I'm sure the viewers who are continuously watching us will definitely stand with my statement of every week the intensity of the quality and the intensity of academics, the standard of deliberations have been going up. And I'm sure we will climb more heights, more horizons. I'm sure with the guidance of the president and the leadership of the IAGES, prime time will become more primer by the week. Thank you and good night, everyone.
Thank you, Kanagwal.
Thank you.
Thank you, everybody. Bye.